Hi, Don here. Welcome to Podiatry Practice Mastery. We're helping you get to the $1,000,000 mark and beyond. So I'm going to go over. This is a recording of a Wednesday in my office. So it was a nice day. We put up this new webpage on urgent care. So it's nice because it's filling up the actual schedule. So I had kind of a light schedule, but it ended up filling up thanks to my staff. Just so you know as well, we are training a virtual assistant. She was being trained yesterday by my surgery scheduler, and she's going to be only answering the phones because we're having a little bit of a hard time answering phones. I just heard we had a little rebellion in the clinic. Not really rebellion, but like the staff, because they don't want to answer the phones, they just turn the volume down so they can't hear them. So they just show up visually and they're not answering them. So it's just so many calls, which is kind of a good thing and kind of a bad thing. But the problem is they're just letting them all go to the recording, and then they get the transcript of the recording, and then they take care of them in the system that we have called Clara. So it's just kind of a funny thing that I heard, funny or sad. Okay, first patient, she's a 62-year-old female. She had a nail sample follow-up, did not show fungus, so I did not do anything for her toenail. She also has a plantar fibroma I am not dealing with right now because it's not bothering her. Next patient was a 33-year-old. This was a little girl. She came in. Little girl, she's 33. I guess I'm 40. I'm 47, so I can call her a little girl. She has some Taylor's bunions bilaterally. That's what she came in for. That's it. And when I looked at this young woman's x-rays, I was like, oh my goodness, what happened? Because she had like no subtalar joint in the right foot and beaking between the talar navicular joint and just all this arthritis. And I was like, what's going on here? You're here for this Taylor's bunion. Is there something else going on? She said, yeah, I had a car accident years ago and my foot's all messed up. I'm like, do you want that fixed? And she said, yeah, it just hurts. I'm just used to having it hurt every day. So I referred her to one of my colleagues for a possible fusion of the rear foot for her. Next patient was a 45-year-old young man. He was on terbinafine many years ago, and he did the whole protocol, and it came back. And so for this guy, I'm doing the protocol again. I gave him terbinafine. He has the UV light, shoe spray, biotin, stuff like that. And I just talked to him about possibly after using topical like Lamisil cream once everything is gone. Lamisil cream once a week. I don't know if anyone else does that, but I've heard about doing that along with the shoe treatment so it doesn't come back. But it came back right on the same toe. And he was totally cleared out in the past, so I started that process. Next patient was a 57-year-old follow-up for Achilles tendonitis. Now, there are certain patients, as I mentioned before, they just don't want to spend money. So these ones I don't spend much time on. I just sent him to physical therapy, and I'm like, if this doesn't work, then we're going to do shockwave for him. I don't really have as much patience. I think shockwave would be better. He just doesn't want to spend. Next patient was a 71-year-old female. She had on the right foot a hammer toe. It looked like a fifth hammer toe, but when I got an x-ray, it showed like a calcific bursa on that area. And I told her, you could remove that or you can just kind of wear wider shoes. I recommended wider shoes for her. Next patient was a patient that came in for a terbinafine follow-up and wasn't really clearing out, so I put that patient on diflucan. Next patient was a 88-year-old person that had a kissing corn between the fourth and fifth toes. Talked about wider shoes, something to space the toes out, and an exostectomy if that doesn't work. Next patient was a 63-year-old that had a neuroma, so I did an ultrasound-guided cortisone injection for that and those neuroma symptoms. They'll follow up as needed. Next patient was a 65-year-old female. She had bilateral second met pain, and I did bilateral shockwave on her. This was EPAT number 4 out of 6, so she has another 2, and she's already starting to feel a little bit better. Next patient was a 56-year-old that had cariflex, one toenail. She's the one that comes in. She likes to do this. She comes in every 3 months for this. I'm trying to get her to see my nail tech, but she keeps wanting to see me. Next patient was a 48-year-old. This is a kind of a nice active guy. He has pain. We reviewed an MRI, and he has some subtalar joint arthritis, bone marrow edema, and kind of the anterior aspect of it based on the MRI. So there's not many options for this young guy. He likes to be active, so he's done cortisone that helped a little bit, but really I'm going to do focus shockwave just on that area of bone marrow edema, so if I can help him feel better with that. So we're going to set up 4 sessions of shockwave. kind of because it's for the bone, I'm doing 4. Maybe I should have done 6, but for this guy, I'm just going to do 4 to start out. I didn't have time to do it with him there. Next patient was EPAT number 2 out of 6 for plantar fascial pain. Next patient, this gentleman, he was kind of a train wreck, I guess. Unfortunately, he had a Lisfranc injury from a motocross accident on his right foot, and he had already had actually on his left foot, and he had a fusion already of the first and second tarsal metatarsal joints, and they were going to do the intercuneiform joints. That's what they were planning on doing, but he didn't come in for the left foot. He came in for the right foot, where he had sesamoiditis from probably his change in his gait. So I talked to him about different sesamoid treatment, shockwave, cortisone injection, but he opted for doing nothing because I think he was here just more for a second opinion. Next patient was a foreign body that she had on the these are some of these that were added on, so that's why I had them written down here. Foreign body that was added on. I got x-rays. I forgot to get an ultrasound on this one. I probably should get an ultrasound. She has a little bump that was there. I didn't really see anything. She didn't want like an incision and drainage. If I could do it over again, I probably would have done the ultrasound. For some reason, I'm always thinking ultrasound, but I didn't think of it. It was funny. My scribe actually reminded me afterwards. Did you do an ultrasound? I'm like, no, I didn't do an ultrasound. So I probably should have. Next patient was a patient with a DIPJ second digit cyst, and we popped it and wrapped it with Coban. She has popped it a couple of times. I went through my whole spiel about the high recurrence rate and needing to fuse the joint if the popping and wrapping doesn't work. And then there was also this is a 64-year-old that she had bilateral second med head as well pain, and she is a shockwave number 9 out of 9. So she's done. I'm going to see her back in 3 months. She's substantially better than when I originally started. Originally, she couldn't tolerate anything. I think it's partially like a nerve issue, and she's better, but she's not perfect. So that's a struggle, that one there. Next was a 37-year-old with a left fibula fracture. Gave her a tall cam boot. She came in from the urgent care. Next patient was a patient had bilateral heel pain. Talked about foam roller. Since she had bilateral heel pain, I gave her bilateral night splints, so she only had to wear them 3 hours instead of 6 hours, right? Switching feet. And then we're still struggling with ModMed. I think we figured out one problem with ModMed for us has been we put in like all the shockwave stuff. I put in like a bill where it shows up when they check out, but the problem is when the staff checks them out, they can't reconcile that bill. So they have the bill I put in, and then they have the payment. They can post payment for $250 for the shockwave, but they can't post it to the actual bill that I put in there. For some reason, it's an accounting issue, so it's a pain. So we have to figure out a different way. A workaround is for us just when we do the follow-up, just to write in kind of what they have going on and how to bill them, what the staff should bill them. So anyway, that's what has been going on in the office. Tell me kind of what's working for you. Reach out to me. I'd love to hear what things are going well. Any new ideas that you have, so I can share it with others here in the program. Okay, have a good one.